Hi, good morning. My name is Neha Sharma. I'm a training director of Child and Adolescent Psychiatry Fellowship at Tufts Medical Center in Boston. It has been my privilege to work with Training and Education Committee as well as Culture and Diversity Committee on conversations around difficult topics of racism and social inequities. And in that regard, the two committees are collaborating to discuss how the current climate and understanding of systemic bias affects our trainees and future child and adolescent psychiatrists. So the title of this lecture is Difficult Conversations of Racism and Social Inequities in Child Psychiatry Training. Again, this is a collaboration by Training and Education Committee as well as Diversity and Culture Committee. During our planning, we found ourselves to discuss how will fellowship programs and education change to prepare the next generation of child and adolescent psychiatrists for future? How will issues of systemic bias, social inequities, and anti-racism be integrated in a training program? How will training programs create safe space to address issues of implicit bias and microaggression within their program? And through our discussion, we realized that these questions cannot be answered without involvement of child and adolescent psychiatry fellows. And thus we created this four-part lecture. And throughout this lecture, we have engaged different fellows from different communities and different institutions to share their perspective, to share their stories, their experiences, and their hopes. The goal here is to display the process of difficult conversation and acknowledgement of limitation while highlighting the movement for change. And also, and most importantly, for us to learn from our trainees. The objectives of this lecture is to highlight the experiences of trainees of minority background, to acknowledge the issues of structural racism and microaggression in training, to discuss ways in which the training programs can address inequities, microaggression, and systemic racism. The main point of this talk is to have safe space. How do we make sure that there's safe space in our organizations, in our programs, and in our environment, and in our relationship? There's no way to grow from and to fight against structural racism and microaggression and implicit bias and social inequities if there's not a way that we can actually keep safe space around us. It is my pleasure to invite you to this four-part lecture. Let me describe a little bit about each part as well as who will be presenting it. Part one is a Pechakucha style, which is really fun. It's a 6-minute talk, very brief, 20 seconds per slide that will be shared by Dr. Amanda J. Calhoun, who's a second-year psychiatry resident at Yale University School of Medicine. She is working with her training director, Dr. Dorothy Stubbe, who's the associate professor and program director of the Child and Adolescent Psychiatry, and Albert J. Solinet Integrated Psychiatry, Child and Adolescent Psychiatry and Research Residency Training Program at Yale Child Study Center. This is an exciting talk. The next talk we have that will be done by Dr. Mio Twin Mint, and this part two is called StoryCorps style interviewing. Dr. Mint is a triple board trained faculty at Tulane University School of Medicine. He's the training director of both Child and Adolescent Psychiatry Fellowship and triple board residency program. He will be interviewing Dr. Piper Carroll, who's a fourth-year psychiatry resident completing her fellowship in child and adolescent psychiatry at the University of Pittsburgh Medical Center. And Dr. Mint will be introducing Dr. Russell J. Ledit, who is a medical student currently, but he also has his PhD in the scientific field, and he is enlisted in U.S. Navy. Part three of this lecture series is actually a conversation between two trainees to share their experiences. And the two trainees who will be discussing their experiences are Dr. Nicole White, who's a chief fellow for the Child and Adolescent Psychiatry Fellowship Program at Cincinnati Children's Hospital Medical Center. And she'll be discussing her story with Dr. Mitch O'Toole, who is chief fellow of Child and Adolescent Psychiatry at Brown University. And the last part is a panel of program directors whom I'll be asking questions, representing questions of different child and adolescent psychiatry trainees. The three training directors who are participating in this panel are Dr. Brigitte Bailey and Dr. Adrian Adams and Dr. Brian Kurtz. Let me just tell you a little bit about each one of them. Dr. Brigitte Bailey is the training director of the Child and Adolescent Psychiatry Residency Program and a professor of psychiatry at the University of Texas Health San Antonio. Dr. Brian Kurtz is the training director of Child and Adolescent Psychiatry Fellowship Program at Cincinnati Children's Hospital. And Dr. Adrienne Adams is the Training Director of Child and Adolescent Psychiatry at Rush University. I hope you enjoyed this series. I look forward to getting some feedback from you. Thank you.
Hello, I'm Dorothy Stubbe. I'm the program director, and I'm here with Dr. Amanda Calhoun, who is one of the residents in the Yale program. Today, we'll be talking about addressing the learning climate in training, and specifically related to systemic racism and mental health inequities. On July 4th, I wrote an email to all of the trainees and core faculty, quoting Thomas Jefferson, saying, "We hold these truths to be self-evident that all people are created equal." And Dr. Calhoun wrote back rather quickly, I might say, "I will never celebrate Independence Day until all people are liberated." And I had the reaction like maybe these guys have. First, I got defensive. What? Is she calling me racist? And then I got mortified. Oh my heavens, my new fellows, all of the fellows, they're going to think I'm racist. And finally, I got reflective, thinking back about what I have put together as our philosophy and 3 rules. The main philosophy, make the world a better place for children and families. And this means being introspective as well as being able to put yourself in others' shoes. Rule number 1. Never worry alone. There's so many things to worry about when you're a child psychiatrist. Did I do the right thing? Am I giving the right treatments? And if you're a Black American, you have even more to worry about. Everyday racism may show up, and our trainees oftentimes feel that they're being treated as a janitor. So what can we do to make it feel safe? Well, Denise Hamilton described how giving an authentic story, being heard, being listened to, and feeling as though the group is supportive, that your story is actually your medicine. Our rule number 2 is play well with others. This adds into the never worry alone. We're working to create a well-being in our fellows, in our residents, in our faculty, and that means being a cohesive group, being able to call on each other's strengths, on our diversity, and to bring the creativity to our groups that come from a well-diversified group with many, many experiences. Our last rule, number 3, you are important. Each person in the team has their own voice. Each person is unique. Each person has their own potential. And what we're trying to do is make a true, robust, strong group that can go and change the world. And in the next life, maybe even in this life, our ideal boardroom would look like this, with a very diverse group, with youth, with passion, with creativity. And I'm hoping that this will be our future.
My name is Amanda Calhoun, and I'm a second-year adult and child psychiatry resident at the Yale Child Study Center. I'm also an anti-racism activist. The fact that I can say that with the support of my program director tells you a lot already. In fact, the protests in this image happened right in the heart of the Yale School of Medicine. Now, some trainees may be thinking, yeah, but many schools have engaged in performative protests. Can you really speak out against racism? Because talking about racism as a Black trainee in a predominantly white institution feels like walking on thin ice. When you start to speak out and cracks begin to appear, will your program support you, or will you be sacrificing yourself, like falling into icy water? Our program isn't perfect, but my program leaders do their best to earn my trust. They actually listen. For this very presentation, when I suggested that we be intentional about centering non-white people with darker complexions to combat racism and colorism, Dr. Stubbe changed her slides. This may seem simple, but it spoke volumes for me. As a Black woman and an activist, I always have a target on my back. Exposing racism in the medical system makes people uncomfortable, and they come at me like darts. But my program leaders support me, so they miss their mark. Because my program knows that combating racism is crucial in our quest to become an anti-racist department and to improve health outcomes for our patients. I speak openly and directly about racism and my dislike of the terms implicit bias and microaggressions. I believe that they are aggressor-centered terms that distract from the real issue, racism in its many forms. I explain that racism is intertwined in the lives of all Black children, like tree branches, and the roots of that racism runs deep, over 400 years worth. I cite the extensive racism that Black children face, like the fact that Black children are systematically undertreated for their pain compared to white children with the same diagnoses or symptoms, like the fact that Black boys are more likely to be suspended for the same behaviors as their white peers starting in preschool, and Black girls as young as 5 are more likely to be viewed as more mature. I talk about how the racism children experience affects their cognition. The work of Claude Steele on stereotype threat shows us that when Black and Latinx children are asked to identify their race, they perform worse on standardized tests than when they are asked to not identify their race. This is due to pervasive racist stereotypes in society that Black and Latinx children are less intelligent. Sadly, a 2019 Yale study showed that racism is alive and well in the minds of teachers. Teachers rated Black students lower in their math skills compared to white students, even when both students had identical test scores and identical approaches to learning. When I was growing up, my parents had to show up at my predominantly white private school to advocate for me all the time. I also blow the whistle if I witness differential treatment due to race in our own backyard. I challenge providers who are contributing to a racist culture by making jokes about a stereotypically Black name or not bothering to call a translator for my Latinx patient's family until late in the day, long after rounds. Because how can we be anti-racist if we can't look at ourselves? So to my fellow trainee activists, know that you are not alone in this fight. Know that your voice matters. To the program directors, please uplift the voices of your trainees. We can't do it alone. And to all of ACAP, remember that we are fighting racism as child psychiatrists ultimately for our patients and their families. Do it for the kids.
Hey everybody, how y'all doing?
Hey.
Hey, what's up, guys?
I just want to actually introduce ourselves. I'll actually start with you. My name is Mio Thuymnyint. I am a training director at Tulane. I'm a training director of both the Triple Board program, which is our integrated pediatric general psychiatry and child adolescent psychiatry, and our child and adolescent psychiatry fellowship programs. And it's a privilege to be part of this conversation. And I'll actually turn it over to Piper so that she can introduce herself.
Hi guys, it's an absolute honor to be here. I'm so grateful that I was asked to join this conversation. My name is Piper Carroll. I am a 4th-year psychiatry resident, currently doing my fellowship in child and adolescent psychiatry at the University of Pittsburgh Medical Center. Thank you again for having me.
Yeah, and I'm beyond elated to be on this conversation because I know it'll enrich not only our lives, but the lives of those who will listen. My name is Russell Leday, and I am a 3rd-year MD MBA student at Tulane University School of Medicine with a very strong interest in triple board residency.
Yeah. And I know that, it's a privilege to actually meet through the American Academy of Child and Adolescent Psychiatry Training and Education's committee, partnership with our diversity committee. And goodness, a lot has been going on in the news and continue to happen. And we want to actually have these conversations to inspire other training programs to have some of the difficult conversations with our trainees, both students, our residents and fellows, and the training programs and the leadership of the training programs like myself, and figuring out how we are going to tackle the anti-racism efforts. But I want to actually start asking you all with some of the basic questions as we actually introduce ourselves. One of the things that I've been thinking a lot about in part of my work with the other marginalized community, like LGBTQ folks, the intersectionality of identities is really important. And some that we can see or make assumptions based on what we see, some we really can't. So I'll start with Piper and see if you would mind sharing some of your identity and how they intersect, especially with your identity of being a trainee.
Absolutely. So I guess some of the identities that I think of when I describe myself would be female, African American, physician, specifically child and adolescent psychiatry fellow. I am a Ravens fan living in Pittsburgh. I am also the daughter of a police lieutenant and the sibling of a transgender male. So I think that all of those things go together to kind of create who I am, and it's impossible to, understand my experience without acknowledging each piece of that. At work, I think the parts of my identity that impact me the most are probably being female, being Black, and also being like a millennial. I often find myself having to like prove that I deserve to be where I am and that, I am a skilled physician. And I don't think that's something that all of my colleagues have to do. I don't know which part of my identity is really driving that. I'm sure it's a combination. But, I remember I have this one memory of like medical school walking in to a room of a patient following surgery to do a follow-up with them. And I was just met with looks of skepticism when they saw what I looked like. And, we spoke, talked about what was going on. And after the encounter, he and his wife said, "Oh, you really are smart. We didn't know what to expect when we first met you." And that was 5 years ago now, and I think about that on a regular basis. So I think that acknowledging the way that our different identities impact the way that we are experiencing training is really important. And I also think it's important for program directors to realize that, all URM trainees have different identities and there's not a one-size-fits-all approach. You've got to be very specific for each trainee.
Thanks, Piper. That's really important. What about your experience, Russell, and your identities?
Yeah, so my first identity is that I'm a father. I'm also a husband, and I'm a Black man. I'm also a heterosexual. I'm an ally, and I think I'm also a Christian. And then in the workplace, I think the ones that stick out the most is that I'm a community activist, and I'm an inspirer. I'm an inspirer, but I'm also someone very keen on letting all of my Black identity come out. And so sometimes it can make for a really uncomfortable environment in a clinical setting. I'm actually afraid that oftentimes we're trained to hide it. And I've kind of fought against that by unapologetically doing some things that otherwise I probably would have curtailed, like cutting my hair or cutting my beard, or maybe not wearing some of the tennis shoes that I've worn before that are stereotypically thought of as ghetto. But I think the one sort of piggybacking on what Piper said that really has caused me to be even more bold is dispelling ideas that Black people aren't smart. Recently, I was on my surgery rotation, and I was sitting in a physician's lounge in the operating room, and I was just sitting there, kind of just looking at some URL cards on my phone, and a physician, I was in there with my attending, and another physician said, "I really wish we could go back to the 1950s. And of course, it startled me, but in my mind, I was like, I wonder where this is going. And then he looked around, realized nobody was supporting it. So he said, it was just much better days and things were much easier to deal with and this and that. And so my attending sort of looked at me and noticed that I was probably about to become irate. And he was like, that probably would have been good for you and I, but for him, he wouldn't even been able to be in this room. And of course, the guy's response was, well, we all had times that were really rough. So those were just good times for us. And my attending said, like, I think our patient is ready, so we should probably go get scrubbed in. And we left it at that. But in that moment, I look back on it, and I think the reason why I didn't respond is because I was afraid of my evaluation being bad. But I also realized in that moment, I didn't know how to respond. Like I was ignorant to how the proper way to respond, because that was the first time something like that had ever happened in that setting. And so I think there's also this issue that I commonly have to mentally deal with, which is not knowing how to respond to things that are jarring, and they happen so frequently till you never get the time to develop proper responses. So you just kind of just internally deal with it. But that's where I'm at with it.
Wow, I'm so sorry that you had to experience that. That actually got me thinking, and that's another thing that I want to actually talk to you all about is this hashtag Black in the Ivory, where Black folks in academia sort of like share their experiences and wrestle just like you just did. And it has been a really educational for many of us to read, but it's also bring out so many emotions. Just listening to your stories, there are waves of different emotions that I'm just experiencing right now. As after you share that, I want to try turn it back to Piper and see if you also have a story that's happened during your training, whether it's personal or the one you read about or heard about, and the different type of emotion that you experience.
There are so many experiences from the past years of training. I think one thing is standing out to me in particular, thinking back to late May when George Floyd was murdered, and the response to that murder. I remember that we did a protest within our healthcare system. There was an 8-minute kneel where physicians, resident physicians and attending physicians from all over the hospital system came together, leaving their clinics for those 8 minutes, came together to kneel in the green space outside of our hospitals. And I remember about halfway through the kneel, I broke down crying because it was so emotional and so difficult, especially when you realize how long 8 minutes is. It doesn't sound like a long time, it's a very long time. And I broke down crying. I was surrounded by my colleagues, most of whom were not Black. There were other Black physicians there, but most of them were not. And I remember at the end of the kneel, standing and looking around, and I saw some of my Black colleagues. They also had tears in their eyes. But we were really the only ones who had responded that way. And it really hit me at that moment how emotional these experiences are for us and how traumatic they are when these events are repeatedly coming up in media, and how different of an effect it can take on our community compared to non-Black physicians. And I think that that's something really important to acknowledge, especially from while we're in training. It's something that our program directors and our peers should be aware of.
Thanks, Piper. As you were saying it, I'm like tearing up because Russell's actually has led of our demonstrations outside of Tulane Hospital, and that 8-minute where my body's starting to shake. There is partly because I'm not used to kneeling that long, but it's just the amount of time, the length. And so appreciate sort of like you sharing your personal experience and the emotions as well. You know, those of us who are working with children, adolescents, and adults, families, and their emotions as a psychiatrist, I think it's really important for us to acknowledge these emotions and, you know, be in touch with them, and figuring out how we're going to use these emotions moving forward. You have anything to add, Russell?
Yeah. So as Mio said, I led a Black Lives Matter protest at Tulane, and as I was talking to him, I told him, you know, if you really think about it, I need for you to take all this energy it takes and inconvenience it takes for you to come out here and stand in the sun, because we're in Louisiana and it's always hot. You know, let your little wrinkled, you know, creased up white coat get a little wrinkle today to come do this. And I need for that to transfer to the clinic and to the hospital. Because this is like falling on deaf ears. I'm tired of people asking Black people how this feels and things like that, when there's like books and books and books and accounts and accounts and accounts of how this feels. I don't think there's something new to be said about how it feels. And I don't think there's a debate about how it feels. But I can tell you, as a person who's new to medicine, I'm always amazed at how brilliantly smart physicians can be, yet how numb they can be to the brain power it takes to just be emotionally connected to your colleagues and what they got going on. Especially when you understand the history of where they're coming from. It's no secret there are only a few minority physicians in medicine. The majority are non-minority. So if you know that, then it isn't that hard for you to take the effort to go one extra step and ensure that they're okay in a working environment, ensure that they're okay, you know, after a really traumatic event with a patient or whatever. It isn't that hard. But part of it is this psychological conditioning that our trauma is a little bit less important because it happens so frequently. Like, we keep saying the same thing, and so because we're saying the same thing, you don't have to value it as much. But the problem is that we're saying it, but a lot of times it's not being internalized. It's being heard, it's just not being internalized and then acted upon. So to Piper's point, for us, yeah, this is jarring. I actually couldn't get on one knee, not because I'm physically enabled, but I probably would have broke down. I wouldn't have been able to stay down there for 8 minutes, because I've seen that happen like before. I've seen a cop's knee on someone's neck in person before. So it's a whole different ball game when you come from these neighborhoods where this is not the first time you've seen police brutality. For some people, police brutality is a new thing. For some of us, police brutality has been going on since police were made. So, you know, that's kind of where I stand on it.
Scott, actually thinking we had a chance to talk a little bit about minority text, which is what you are also alluding to, Russell, the extra burden of the Black and brown and, you know, other people of color sort of somehow have to take on to state the same thing over and over again, or the obvious things. Pepper, would you like to comment a little bit more on that?
Sure. Yeah, just like Russell was saying, there has already been tremendous effort put into discussing all of these topics. And yet, as all of this has been coming to light in recent months, especially. It seems like every other day I get, an email, a text message, or someone stopping me in the hallway to ask me personally, Piper, what do I do to help Black people? And it's frustrating to say the least. On top of that, this is something that I do feel extremely passionate about, and something that I absolutely want to get involved in and to continue to work on. And I want to be an advocate. I want to be an ally. I want to do everything I can to create health equity for all groups. At the same time, I can't do it all by myself. And I'm already a resident, which is an extremely demanding part of my training. And so learning how to balance those two things, I think, is really important. And one thing I think we need is mentors to show us, this is how you create this balance. This is how you make the difference, and you don't totally burn yourself out. So I think that's where I'm at, trying to look for those mentors within my own institution, and then, in psychiatry and in medicine as a whole.
Yeah, the irony is not lost on me that we're doing the same thing. And I'm asking you to, and we have asked, and we had a lot of discussions when we were preparing for this, and, hope that this is not a additional burden to y'all while we are trying to actually use all the available resources to educate ourselves. But really, again, appreciate you guys putting in the time, energy, and energy, that have to relive some of the trauma that you all are actually talking about. So I appreciate that, and that I am very much aware of what we're doing and things that we are talking about. As we're wrapping up, though, in addition to everything that we are going to work on just to actually, elevate your voices, what are a few other important things, and you have said it throughout this discussion, that you will want the medical educator like me, or somebody who wants to actually mentor some of the things that Piper you have mentioned, to know, to aware, and the next step is actually to act and to advocate, right? Using our privileges and our positions. What would be the next step that would be something that we can and should absolutely do?
I'll start by saying that I've been singing from the mountaintops for a while, which is I genuinely believe to be qualified to be a physician, you need to read Medical Apartheid by Harriet Washington. There are a lot of other books out there that help people to understand the history with which medicine has progressed, especially the ugly past with regards to Black people. But I think that sort of helps people to frame a lot of some of the baggage and history that we carry, because I grew up with my grandmother telling me about some of those stories of Tuskegee and some of these other things. And she would tell me, I'm not taking that medicine. I'm not doing this because they just trying to kill me, or they trying to get me, they don't really pay attention to me when I go there. They don't understand, they don't listen to me, or this and that. But if you have that knowledge in your background, right, when you're trying to talk to a patient, then you appreciate them for some of the stories and some of the things they're trying to bring forward to you, and the way they're communicating it to you. Some of their skepticism, some of their doubts and their fears are rooted in real issues that we've, as a country, has sort of just swept under a rug. And I think the other thing is, which I personally know Mio does an amazing job of doing, but is unapologetically advocating for the trainees. Not necessarily just the ones who come from marginalized backgrounds, but understanding that a real training environment needs to be one in which every trainee feels like they can thrive. When you think about the history of minorities who have traversed all this different educational environments to get to, like, you know, either almost being a physician or being a physician. And you know the history of America, you know that they've experienced some really tough, you know, situations. So if you take that into account and they're taking that back into a patient's room, and then the patient triggers even more, some clinician who's at the mentor level, the attending level, the sponsor level, needs to nip that in the bud right then and there. Because my mama used to say that saying about there is a straw that will eventually break the camel's back. There is a straw that will eventually break Black people's back. Especially us who have worked so hard to get to this point in medicine. We can only take so much. That's just the truth of the matter. And so somebody who has a little bit more leeway because they haven't experienced all this extra trauma needs to sometimes take on the burden and make sure that it gets rectified so that this doesn't keep happening. Because you actually run people away from medicine. I'm not going to convince my child to go into something if I know the environment is not conducive for them to thrive, you know. So that's just kind of the way it is, or that's at least the way I see it. I think mentors and sponsors need to know that it is imperative that you unapologetically take up for, advocate for, sometimes even intervene on their behalf, whether it's with your colleagues or with other trainees or with, you know, med students or even with patients. If we don't have that safe space or that safe barrier, eventually we gonna shoot the deuces and go somewhere else.
Thank you, Russell. Piper?
Yeah.
I think that just like our programs, specifically in psychiatry, work to teach psychopharmacology and psychotherapy and you know, all the different aspects of psychiatry. I think that we also need to teach how to advocate for health equity. Like Russell was saying, it's an essential part of being an effective physician. And it needs to be something that is taught in our training programs, just like any of the other things we learn. And that starts with the history of race-based medicine. That starts with the history of why our patients look at us with mistrust so that we can understand where they're coming from. And then that extends to teaching all residents how to advocate for their patients and how to be allies to their patients, and teaching them to recognize where the structural racism within our country may be showing itself in their own practice. I think that it's essential in order to build effective physicians, and that's something that all programs need to start doing. It should be an ACGME requirement.
And as you all have mentioned, the tools are already out there, and people have correlated the sample curriculums of how we actually need to take that. Thank you, both of you, to taking time and again, a lot of energy to allow us to hear your stories and share, some of the experiences that you had and some of the hope that you have for all training programs. So thank you so much.
Thanks for having us.
It was an honor to be here.
Yep.
Hey Mitch, how are you?
Hey, I'm good. How are you doing, Nicole?
I'm doing well. It's good to see you.
Yeah.
So I really wanted to talk to you about a patient case that I was involved with within the last year of my training, because I'm curious to hear your thoughts about it and if you shared similar viewpoints as I did.
Mm-hmm.
So I was working on an inpatient unit and preparing for the new admission. And one of the first things I always notice is the picture, because that pops up. And I noticed that the patient was Black. And then I went to see the admit note. And the first thing I saw on there was a diagnosis of conduct disorder. And so I'm like, okay, this this patient is elementary school age, so I'm thinking, man, she must have done something really intense to have that diagnosis. So I'm looking through the chart. The things that are really sticking out are significant trauma history and that she's adopted, and has only really been adopted for the past couple years. And so then I scroll to the bottom to look at the assessment and make sure that I saw conduct disorder. And it said that in the note as well, that she was diagnosed with severe conduct disorder, childhood onset. And I found it really odd because this was an outpatient visit with a provider that she had never seen before. So this is an initial visit.
Oh, the very first time.
The very first time. And all of her trauma history. So I was really trying to understand, and I kept rereading the note, trying to figure out, well, is there something I'm missing for why she was diagnosed with conduct disorder as an elementary age patient?
You weren't seeing that.
I wasn't seeing any explanation. And so the thing that kept coming up in my mind was her race, that she was Black. And I kept thinking about how, that's just what is happening in this country and what has been happening in this country, and the narratives that are placed on Blacks in this country, that they're more aggressive, more violent, more dangerous. And so these things just kept going through my mind, and I felt really angry and sad and frustrated, and was thinking about, well, how can I advocate for this patient? What's my attending going to say when I bring this up? Should I bring it up? Is the team going to be responsive, or is it going to fall on deaf ears? Are they going to say, well, here goes another Black person talking about race? I wish we could just move on from that and just kind of be ignorant to what the concerns that I had about this case. I don't know. What are your thoughts on hearing about that?
I mean, I think as I'm hearing about it, I guess I connect to like your emotional feelings about the kid herself and, what this diagnosis means for her. But then also your feelings about, okay, within the system that you work in, okay, how do you affect change in there? And
right.
Not only that, the other part for you, it seems like, is, oh my gosh, how do I bring this up, and will it actually move things anywhere? And then how do I get seen when I bring these things up? And I think that's one of those things that, I deal with too. And I myself have to sit back and have that balance of, as I'm working throughout the day. And I think it's one of those situations where so often we hear about these different systems that affect our patients, and we think about it sometimes from such an academic level, but then we don't always bring it into the room. And I wonder if that's where you're seeing some of the issue with the diagnosis of this patient. Because I think from what you're saying, you might think about a PTSD diagnosis kind of like the bright lights flashing.
Exactly.
And, it's being framed in such a different way. And what you're getting at, I think, is that feeling of, is there more that's playing into why she's being diagnosed in this way, other than what was in the room in front of this clinician?
Yeah, that's such an excellent point. That's exactly how I felt, because I think, to your point of how that diagnosis can really shape a young child, all of the stigma that's going to come with that, and the treatments, the differences between treatment for PTSD versus conduct disorder, and how she's viewed, you know, if that diagnosis is shared with teachers and the school system. So it just carries so much weight. And again, like I said, my fear of her being Black already, that's there. That's kind of the perception that a lot of us carry. I know myself that I have always had to think about and navigate being a minority. I'm Black and Latina, and thinking of how am I being perceived when I speak? Am I going to be seen as an angry minority girl, an angry Black girl, if I speak passionately about something, if I speak up about something, because we know those stereotypes exist. So it was really hard. Fortunately, it was, when I spoke to my attendant about it, it was received well. But I'm curious, you know, are there other cases that you've experienced or other sort of experiences that you've had? Because I know that this is happening a lot within the system, right? Like, this isn't just a one-time random case.
Yeah, I think, unfortunately, it does come up so much, you know, that it's unfortunately universal, where I've seen so many of these cases, you know, in my 1 year and a couple months now of child training. It happens so much in adult training as well, where, you know, I felt that tension that you're talking about too, of what do I speak about? How many of these things do I speak about? Which situations are the ones where I speak up? Which ones do I unfortunately have to let go? And, you know, who's going to be a good ally? And there's so much running through my head in those situations that it gets hard, and you sort of, in some ways, are kind of stuck. You kind of get frozen in that moment of, okay, what is the best next step right now? And I don't know if during that case, that's what you were feeling in that moment, where you just kind of had to sit there with that, maybe a pit in your stomach of, something's wrong, what do I do? And just kind of take that next breath. It sounds like that's what you're describing.
Yeah, definitely. And I think your point of just trying to figure out and navigate which cases to speak up about and which ones we sadly have to let go is a good point. How have things been for you, you know, just as a Black male in your program? I think I carry the weight of and the burden of, you know, if I'm the only one here, then I want to be able to speak out about these things and make sure that it's paid attention to. But that's also, you know, a huge undertaking and can be exhausting.
Yeah, I mean, I think on top of the hard work that we all have, you know, to pile something else on that's so big and, like you're saying, such a massive undertaking, that's a big thing to ask. And I really think that it's hard to do, and it's necessary. I feel like, luckily, I've had a lot of good support from people here in my program. I felt in that same way last year, where I was the only, you know, Black person, Black male in our program. I very often had to kind of sit with these things and know that, well, I may be the only person who's coming at this with a personal perspective to add. And there's something very different about that personal perspective, because it changes from, you know, a moment of, well, strategically, like, what do we do, to, hey, this could be my my child.
Yes.
This could be my father when I was working an adult. This could be my sister when I was working an adult.
Exactly.
And it really just changes the calculus there. And I think it provides another dimension to those discussions, and also kind of like you're saying, puts that extra burden on us to provide that in moments where it may really feel difficult to.
Right, right. Well, I'm glad that, you've had that support at your programs, and I also have felt extremely supported at my program. And I think that that's really an important message to share, is that, if we're going to have progress, we need people, we need allies that are going to be willing to do the hard work, to listen, to understand that you might not get it right. None of us get things right 100% of the time, but that you actually genuinely care. Caring about your residents and fellows and the patients that you care about takes you being able to see them for everything that they are, and being able to be curious about my experience as a Black and Latina physician at your program, because there are differences, and to be open to that. I think that shows that you actually do care, and that shows that you are willing to learn and explore what that means for me. What do you think, Mitch?
I think some of those, like the biggest moments that I've had, or like some of the best moments I've had, are when I have brought up things like that, and the other person who I was sitting across from said, yeah, I had never thought about it in that way. And they were just so interested to hear more about that and understand how they could explore those things themselves if they found themselves in a similar situation. Because something that for me might come up and, there's flashing lights everywhere, and I'm like, oh yeah, I totally saw that. For them, they were like, oh yeah, I wouldn't have seen it that way. I may not have noticed.
Right.
So I think that personal growth that people feel, that's one of the biggest things that I think are super helpful to moving things forward.
Yeah, I agree. So how do you take care of yourself with everything that we're dealing with, everything that's been going on, the things that we're seeing within our communities, patients? What kind of things do you do to help yourself, practice wellness?
Yeah, I think some of the basics, of staying active, sleeping as much as you can, those things, of course, are always going to be in there. And I think also just feeling effective. I think I had talked with you a little bit about one of the groups that got started here around May, Code Black RI, where there is a big group of people who are working together, putting together so many initiatives, like working with the residency programs here, working with the Department of Health.
Wow.
So just feeling effective in that way has really changed, how I feel like things are actually moving. And I think that's been a big part of, my wellness and my growth.
Yeah, that's fantastic. I definitely think community building, either with other residents and fellows who look like you, that you can trust, and also, finding that sort of niche or the thing that you're going to be passionate about, the area that you feel like you can actually help to bring about change can definitely make it go from like this huge, big problem to something that's really focused, where you can actually dedicate your time. So that's definitely helped me during my training.
Yeah, I think in that way, like so much of this is going to be like a problem that no one person is going to be able to solve, and
Exactly.
we have to find our chunks of it that we can kind of attack and make better, and then move from there. So I really like the fact that you're thinking that way about it.
Well, thanks, Mitch. It's always so good to catch up.
Yeah. Yeah, it was good to hear from you about like everything that's going on, and I really appreciate just hearing your perspective on, that case and just where it took you in your thinking.
Yeah, definitely need more of these difficult conversations.
Yeah.
Welcome. My name is Neha Sharma. I'm a child and adolescent psychiatrist at Psychiatry Fellowship Director at Tufts Medical Center. I have a privilege of inviting wonderful training directors who will share with us about issues of racism and how that affects trainees and the questions that trainees may have that they are hoping to answer for us. So this will be a wonderful panel where we all get to learn about how to address issues around racism in our organizations. First, I have Dr. Brigitte Bailey, who's a program director of the Child and Adolescent Psychiatry Residency Program and a professor of psychiatry at the University of Texas Health San Antonio. I also have Dr. Brian Kurtz, who's the program director of Child and Adolescent Psychiatry Fellowship at Cincinnati Children's Hospital. And lastly, I have Dr. Adrienne Adams, who is a Child and Adolescent Psychiatry training director from Rush University. Welcome. I am so glad that you're joining me today, and I really appreciate you answering some of the questions that fellows from throughout the country have shared with me. The first question I have is, how could child and adolescent psychiatrists be prepared to address impact of systemic racism on child's health in their individual work with patients?
Wow. Well, I think that's really a great question. And I'm going to start here because I like to think of it from a top to down proposal. So I think definitely think about from a program level. And I think as a program director, we're in that seat of being able to make sure that we make these changes systemically and unilaterally for rotation. So I think definitely thinking about your rotations during your CCC meeting, which is typically the meeting that we have with all the, I would say, the power brokers within the fellowship or residency program who are there to make sure we're providing a great educational and clinical opportunity for our trainees. So I think typically during that annual meeting, even when you're going over your rotations, to kind of decide how can you incorporate some of these important issues into the rotations themselves. Like, for example, we were talking about our forensic psychiatry rotation, and typically we work with the juvenile detention center. And as we know, in a juvenile detention center, typically there's a higher rate of African-American youth that are incarcerated versus, I would say, non-Black youth. So it's really important to think about, how can we enhance that experience? And that would, no-brainer, systemic racism or structural or institutional racism would be something to think about. So we're incorporating didactics or education opportunities about racism within that clinical rotation. You would also think about maybe other ones, like say your outpatient clinics where you're working with various youth, thinking about health disparities and incorporating issues so that your trainees are not only thinking about the symptoms, but also thinking about whatever healthcare disparities that could occur with those patients, such as, medications, environment, where they are, family dynamics, the whole issue. So I think definitely that's one of our bigger things as a program director we're able to use, our bigger tools for our, I like to say, our toolkit that we use in order to get things done.
Thank you. That's very helpful.
Hey, I will go next. So to answer the question, one of the things I do in my program is we have a psychotherapy clinic like all of us. And I have group supervision. So not only do they have their own individual supervisors per week, we also meet as a group, and one of the fellows will present their case. And we kind of go through the family tree, as I call it. So we look at multi-generations and see if we find patterns. But this is a way that we talk about the impact of race, the impact of their communities, the impact of unemployment, poverty, besides the psychiatric illnesses that we look at, or the generational lines of abuse. And this tends to come out where you decrease the emotional vulnerabilities by diffusing a lot of things in group and having group discussions. So when I talk to folks about countertransference and transference issues and potential that it could be race, could be gender, or your own personal issues that are being reflected in the therapy, you can see the wheels turning for the other trainees saying, I never thought about that before. I hadn't thought about that angle. So I think the group learning helps bring up a lot of emotionally charged issues that we deal with our family, and then you learn vicariously with it. So it opens up the discussion of how, our feelings and thoughts by what the patient is telling them in our group therapy and how it reflects back. So I think sharing and making it a learning opportunity for us all, because we pull on the different cultures that we have. So we use us as experts sometimes if we have patients of color, patients from another country that someone in our group has similarities to. So then we talk about the cultural impact of a firstborn son, say for a family who has now schizophrenia. And so seeing some of those families lose hope and lose their dreams because of what the culture has for the firstborn male. So I find all that pretty interesting. And then we just try to use each other's expertise, or what we call our general knowledge about certain things, to diffuse a lot of issues that come up, including the social injustice that we're watching here or anywhere else in the country when other issues for women come up.
Well, sounds very organic.
It is.
Dr. Kurtz?
I think that's a really neat way to kind of accomplish, the goals that you would have as a training director to create space for this topic in a group setting. I think definitely I do a fair amount of work with, fellows one-on-one, either rotating on my consult service or in individual psychotherapy supervision. And I think, I think of this as a learning trajectory that everybody is on. Every trainee that you work with is on their own trajectory as far as, the level of baseline knowledge that they have relevant to this, the skill that they have for integrating it into a biopsychosocial formulation as they're talking about patients, and then sort of thinking beyond that into sort of like the family or the community that they're working in. So I think I try to model that, talking about patients and families with attention to, how racism has impacted them, so that it's clear that that's part of what I expect when, in terms of a full description of what might be going on with a patient, and thinking about what are the things that we would expect could be helpful for this patient and for this family. And I think also being aware that for most, possibly all cases, that we can talk a little bit about what we want to do for this patient or this family, but there's also a great many things that we won't be able to accomplish to really take away the negative impacts of systemic racism, and that these require different levels of changes in the community and in society in general. So I think, when I'm talking about those things, I try to model them, and then when I feel like a particular trainee is a little weak on being able to include that, that's okay. But where is the next step on their trajectory? Where are they headed? What do they need to know more information to be able to incorporate that? Do they just need more practice in how to do that? Because we can certainly provide that in a supportive way.
And if I could add one thing, when you talked about there's a lot of systemic issues we may not be able to do anything about, but I think validating the family's concerns and thoughts about their feelings and impact of what's going on and how it makes them feel, just acknowledging it, I think goes a long way than say even 2 years ago.
I agree. I really appreciate all of your responses. I like, Dr. Kurtz, you've kind of shared with us your developmental approach and more on the individual basis of how to address it. I appreciate, Dr. Bailey, how you kind of suggested the supervisory or a group way of supporting and creating a culture of talking about the impact of systemic racism. And Dr. Adams, I appreciate your way of having like a program level approach, a larger top-down approach to address this question. Thank you. I do have another question for all of you. This is a really good one and definitely touched my heart because I feel that it came, and during my training, this came up quite often and even since comes up quite frequently actually. So the question is, what do you think is the best approach to dealing with microaggressions as a trainee who may be concerned about the power differential and voicing these concerns? It's a hot one.
It definitely is. I think I'll take this one first. And it is a great question because you think about the power differential, and it is huge when you are trying to make yourself vulnerable by talking about these issues and you don't know how that person's going to respond or even if they really care. So you need a safe space to do this. And so my advice is to find a mentor or an advocate for you who is in the system. So as soon as you come in as an intern, Cap 1, you look for a faculty advisor, mentor, or advocate. But, sometimes programs match you already when you come in because you really don't know faculty. And this is sometimes good where it works and sometimes it doesn't work. If it's not working for you, where you feel you can be vulnerable and talk about these microaggressions without fear of repercussions, then you need to find someone else. Ask around, talk. Sometimes it may not be in your department, it may be in another department, but you need to make an effort to search. And then once you find this mentor, they need to be willing to go to bat for you, right? To support you and fully represent you, say, to other faculty and to leadership. And most of the time, we get through training with no problems. But if you're the one that it's going to happen to, you want to be prepared for it. And having that mentor and that advocate is going to take you, because they can help you fight those battles at the faculty level and leadership level that you cannot do for yourself because of the power differential. So those are the first things that you need to do. But remember, training directors, no matter how open they are, no matter how they are intentional in dealing with racism and other things that are detrimental to our trainees, they have a dual role. They are here to support you as fellows, but we also have responsibilities to the program. That's why having the extra mentor is important. So your training director will be in there for you, but at some point, just say if it comes to a disciplinary process, then your training director has both roles and you want someone fully available for you to help you fight that battle. So my other one thing to say for you trainees, if there's a situation that comes up with microaggressions or anything that's feeling uncomfortable, don't wait to report it. So even if you think your training director is not as supportive as you would like, those incidents need to be reported right away because someone else is going to report it for you. So it's better for you to go in and talk about what happened, what your concerns were, and if you think, and what the next steps are for you. So be available to your PD when these situations come up. And if I may, I'd like to kind of share a personal experience of what I used to tell interns when I used to teach ethics sort of early on in orientation week. And my goal was, I'd say, well, we're going to seg out of ethics for a second, but I want you to find a mentor because you never know. You got 4 years here because I was in the general program teaching besides the child, but you never know when you might need it. So I understood later on for people came back and told me, you know, when they were further along or actually after graduating, that people would get so mad that I would bring this up, that you would need a mentor because that's the only person who's really going to go to bat for you and stick up for you. And then one person came back and said, you know, Dr. Bailey, I'm so glad you told me. I was mad at the time, but it really was helpful with a personal incident that happened with some microaggressions further on in my training. And so even though I didn't appreciate it, you know, you telling me initially, because, you know, I had there was nothing to say that this is going to happen to me, and I didn't think it would, but it was really helpful advice. And so it made me feel better that I was doing something, even though people didn't like to hear me say that year after year, that you need a mentor.
On that point, I had a question for you. Is it important that the mentor share the same ethnicity or race or background with you?
No, it wasn't important for me. I mean, you sometimes you want someone who looks like you because you think that they're going to be helpful, but sometimes that's not the case. How you do it is based on how you feel about that person and what they are showing you as far as support. Can you talk about anything? Have they been willing to go to bat for you for other things? What kind of advice are they giving you? So you're going to have to use your gut feeling, so to speak, as, is this person important? But we don't need to look alike. We don't need to be the same sex. We just need to have that connection, because you feel when you connect for something. And if you don't feel that connection, that you don't have words for, then maybe that's take a step back about exposing yourself, because you don't want repercussions to happen to you and you don't want to interrupt your dream.
Thank you for clarifying.
Yeah, I was going to say, I cannot agree more with you, Dr. Bailey. I mean, I definitely think, yeah, and even with mentors, I think it's always important to even think about, if you connect with someone outside of your institution, then to go that avenue. Because sometimes you and your PD might not always click, so it's important to use that as an avenue. But yeah, you know, in thinking of your question, you know, I was thinking more also about with microaggressions, that not everyone recognizes that things have occurred. I realized even within, you know, institutions, even 5 years ago, I think there was a thought among many leadership that we have our mission statement there, so there's no racism, no discrimination at our institution. So if we don't say it and see it, it's not there. But we all know it's really there. So, you know, I think one of the big things to do for microaggressions is to make sure you're educating not only your trainees, but also all the staff that will be working with the trainees. Because I think it's really important for people to know what microaggressions are. It's not something for you just to ignore, because as we know with microaggressions, they've shown in many studies now that it can affect health-wise, as far as for people of color, increased risk for hypertension, diabetes, lower self-esteem, all that. So it is a serious health determinant. So it's something to be aware of. So definitely, I would say make sure that you're providing lectures, open spaces, safe spaces to talk about microaggressions. Because this kind of reminds me of when I was younger or early in my training, I would sometimes have situations that would occur or happen against me, and I'll say it against me now. And that at the time I just would feel like, what was that? And I would feel uncomfortable, but I wasn't really sure why, if it was really okay. Maybe it's just me. Maybe I'm being too sensitive. But it was, you know, through talking with other people that I realized, like, no, you just had a micro invalidation, or you were micro assaulted, and it's not okay. So I think unless trainees realize that things that occur to them, that's not okay, and it's okay to bring it up, you know, we really won't have change if people ignore it. But you have to be able to recognize, of course, that something has occurred. So I think it's important for the whole department, all departments, institutions, everywhere, to be aware of what's going on and how we can make change.
I appreciate this. It sounds like you're really making sure that microaggression is part of the conversation, again, on the program level, as well as interpersonal level with other faculty and other fellows and so on.
Yes.
Thank you.
I think, yeah, I think Dr. Bailey did a great job of kind of outlining how you want to approach this issue as a trainee, you know, what strategies, the idea of how you can strategically position yourself with mentorship and things like that. And I think Dr. Adams did a good job of kind of outlining some of the issues from a program level. Maybe something for me to kind of add as a white program director is that I should be expecting that microaggressions are occurring. And if I'm not hearing about it, it may be that the issue is that folks don't feel comfortable telling me about it. Not that everything is hunky-dory, because that is, it's very easy for it to be invisible to me. And so I need to make sure that I'm going the extra mile to ensure that people know that this is an okay thing for us to be talking about, that I'm receptive to hearing about it, and that I'm really wanting to be intentional about making the environment in which they're working and learning as conducive to that as possible. Microaggressions are clearly going to make people burn out faster. They're going to make people feel less supported and less like they are working on a collaborative team. And it's gonna take energy away from the wonderful contributions that they have to patient care and to our profession. So I mean, I think, you know, I have a role to play in making sure that this is a topic that we can talk about. And if by some chance there are faculty or other trainees in my program that aren't accustomed to doing that, then I need to do some work to help get them more comfortable in that space.
I agree. It sounds to me, what you're saying is that we have to be sensitive to the topic, and unless we ask and keep our eyes open and be vigilant about picking up potential of power differences and how they're playing out in our trainees' life and in our faculty's life, we're not going to necessarily see it, and it's not going to be catered to us. It's not going to be, you know, shared with us on a silver platter. It's something that we have to dig for, and that's the best way we can have a safe space for our trainees in the program, while making sure that everybody's being educated and understand that this is a thing on a more professional level, and creating maybe an environment of having mentorship in the process. So you're almost like addressing the problem or creating a foundation to address the challenge or the problem before it even happens. That's beautiful. I feel like I'm learning so much with all of you. The last question I have for all of you is, what resistance have you come across personally in addressing systemic racism, and how have you navigated that? Because we all hear about systemic racism, but it's, you know, all of us maybe have some ideas about how to address it. And in all honesty, I feel like I have very little control, and the control that I do have is only just in my own program. But then there's resistance from the culture of an organization. I think an organization tends to be stagnant when it comes to changing, or resistant to changing. And we're working with many people from different generations, from different mindsets. How do you deal with that? I know, that's a big question.
Yeah, that's a good one.
You want to tackle that, Adrian, or you want me to?
Well, you know, I think it's definitely, once again, going back to that education component. So I think as a program director, we're kind of like the standard bearer that when things come down or there are changes, we're often the ones that have to implement the changes, along with the help of hopefully our section chair and department chair. So I think definitely as a program, having access to multiple resources to share with our CCC committee or our supervisors for our rotation. So things like sharing literature and and being proactive about conducting discussions on racism. So that's, once again, that safe space of making sure that your trainees feel comfortable coming to you to discuss issues that might happen either with patient care, where there is some type of discriminatory action, or even with another attending. So I think that's important. I think also discussing current events. As we all know, things with George Floyd, as well as what the recent murder in Milwaukee. A lot of our patients are coming in with these issues, as well as our trainees. We've had trainees during the, I don't want to say martial law, but what was actually the thing that happened where they made the cities kind of, due to the protest. So we had to show our IDs. I know there were a lot of trainees that were actually stopped along the way as first responders to come to the hospital, and they had to pass by police checkpoints in order to get across, and that was pretty scary for some of the trainees. So I think definitely, having an open dialogue regarding the current events that are occurring and how it's affecting you as a trainee, as well as how it's affecting the patients that we see. I think definitely real important to conduct cultural competency courses, because I think if not all our professors or attendings are on the same level or understanding, I think that's going to be a problem. I mean, we definitely have some great attendings out there, but if they're still using a lot of their teaching from the 1990s, they're not keeping current. I'm sure no one's doing that, but I'm just saying it's really important to make sure that we're all culturally competent so that we're, really helping to train our trainees to be child psychiatrists in the current stressors that we have to deal with. And I think, as always, having experts, if we can get experts to come in and do grand rounds for us or from the local community to talk about specific healthcare systems and health disparities. I think if we can have experts come in and do courses for all of our staff regarding implicit bias training, because we know that that's something that a lot of institutions have been doing, the implicit bias testing training. And I think the bigger thing that I want to bring up as a minority person is kind of not expecting all the work to be hampered on just the few minority people that you have on staff. I know a lot of times, and I guess I might even be the first African-American associate professor in my department, there are a lot of things that happen, and it's kind of like, well, what do you think, Adrian? But I think it should be more of a collaborative effort with everyone and not just the underrepresented minority people expecting to take the lead on things.
Thank you. I completely agree with you. One thing that I really liked about the ACGME is the new milestone on wellness and diversity. And to me, they go hand in hand. So it has given me an opportunity and a platform to kind of feed more and more lectures on the topic and bringing this into a reality for the larger organization, that this is an issue. If the ACGME is bringing it up, it's not something that can be easily dismissed, and we need to make sure that policies are changed, that our system of addressing complaints, our system of addressing these issues is more solid and is actually inclusive of larger population. So just like you're suggesting, to kind of bring in education, bring in policies, kind of keep people going along and current has really, really helped. I am curious, Dr. Adams, how did you talk to your trainees who must have been affected with the IDs being checked by the police officers? How I just feel for them.
I know. I mean, I think it's once again that part of just knowing that I hear them and telling them, I have, they have my number on their speed dial. I'm like their biggest advocate. I actually did offer someone that they could stay over at my house for a little bit if it made them more comfortable and we could drive in together. But that was probably that mother hen and me as program director coming out. But yeah, I think just knowing that they're heard and they're supported, and that, as a program, we're all there to help.
Validation. Mm-hmm. Thank you. Dr. Bailey, did you have any thoughts, or Dr. Kurtz?
Sure, I will go next. I was going to talk about a little personal experience I had with, because Dr. Adams talked about having cultural competency courses. And so I was selected to teach cultural psychiatry for a year or two, because the previous person had stopped teaching it. And so I was thinking about different ways, because, we have a diverse group of residents, and this is, again, the general program. And so I was trying to make it as non-threatening. So one, just using terms that we needed to be familiar with and definitions. So I had, pre and post test of definitions of race, ethnicity, culture, other culturally competent terms that were highlighted at that time. And all I had to do was match them. And then the second exercise was to write a cultural formulation, right? Because we do that for our patients. And so it's anything you want, write about your history and your culture. And there was a lot of resistance into, why do we need to know these things? And, what if we don't have a culture? I don't really know what to write. And so it became more of a lot of resistance and challenging to not want to be, you're required to be in didactics, but the tension in the room for what I thought was pretty non-threatening just kind of escalated for a while. So I would kind of talk about and relate why we need to know these things is because we're going to see diverse patients. And we want to educate ourselves so that we don't become part of the problem because we are unaware of what we bring to the table when we interact with patients. And so I taught it for a couple of years, but it became overwhelming for me personally that, I didn't have enough energy to change the cultural of the training department or the psychiatry department or a medical school at that time. And so I stopped teaching it because I found I was just worn out and overwhelmed with trying to contain a lot of the emotions that were going on for, the ideal is that we educate ourselves so we can be better for our patients and interact better with our colleagues. And it became refreshing at one point. This young white trainee director a year later came back and said she, didn't think it was worth it at that time, but she understood why she had a Black lady who was hesitant to come on the unit because she didn't have the things that would make her comfortable, right? So, you go back to the old school, we think of, this person's suicidal, but they're not really thinking of what you need. But here you're thinking of hair products, certain combs that we need to comb our hair, things that are going to make us feel that we are individuals and that people care about us. And so she came back and said that, she worked with the team to have this lady have products that she would feel comfortable using or needed every day in her routine that the unit didn't supply in the kits that they brought with them. So again, it was validating that someone listened and someone learned later on the value of why we have these discussions and why it's important for us. So, you can get resistance at all levels, but as trainees, being open-minded and opening yourself to different experiences, different cultures to help you be a better physician to the diverse population you're going to treat.
Thank you for sharing that. And I also appreciate you acknowledging how kind of keep pushing for this fight, to keep pushing for this message to kind of be spread and shared by different entities can be exhausting. And that how, going back to what you were saying, Dr. Adams, that it's not something that one person needs to hold. It's something that needs to be shared upon and collaborated. And I appreciate you, trying to impart this education to so many people. Thank you. Any thoughts, Dr. Kurtz?
Sure. I think both what Dr. Bailey and Dr. Adams have said, just I think resonate with what I've heard from my trainees in terms of what they've experienced and from some fellow faculty as well. So I'm thinking about Dr. Adams' point that if the only individuals who seem to be bringing up issues related to why it's important to have diversity amongst our trainees and our faculty, if the only people bringing that up are minority faculty, then I think that's from what people have told me, it's just an exhausting experience. It's just a further drain on the important work that you're doing. So, I think as a white faculty member, I think it's important for me to reflect a little bit on my own privilege for the fact that I will work with many trainees who will have experiences that I don't have to experience, that I have not had to walk in those shoes. And I think that many of the other faculty that I work with will also similarly not have had those experiences. So I think, one thing that I can do is to try to model for them some recognition and spelling out of some of my white privilege, and a little bit about sort of how I think it would be appropriate and important for me to try to position myself with regard to my trainees as someone who could be counted on as an ally, both to just kind of be a listener, I think, which Dr. Bailey and Dr. Adams have kind of talked about how important it is to kind of be able to validate, and then also take action when it's appropriate. And so depending on the circumstance, there's kind of both things are relevant. But, I think about, talking to an older white faculty member, very nice person, and talking with that person about how I had been working with a trainee who was describing how when we had some curfews in place after the murder of George Floyd, we had, he was very conscious about how he would be traveling to and from the hospital, how he would be positioning what was in his car, where his hospital ID would be easily visible, and he wouldn't need to move his hands to anywhere unpredictable, to get, to get his ID to be able to show it if he were stopped by the police. This was actually by far not the first time that he had thought about this as a black man working, as a black physician. I can't relate to that. It makes tons of sense to me, sort of, that he's had to do that. I'm sad that this is needed to be the case, but it wouldn't occur to me unless someone told me that this was how they live their lives. And I think also for some of the other people that I work with, they don't see that. And so I think that is part of what we can do, is we can hopefully amplify a voice, right? So this was a person who had shared his story with me, and then I can be a conduit for that voice to be sort of heard by other people who are in a position of privilege like me. And I think that is the best way that someone can try to be an ally, is to take a voice that's important to be heard and amplify it.
Thank you for sharing that story. It's so sad that so many doctors of color have to go through this, but it's such a reality. And it's just so sad that we're in this time that it's still a reality. But I also agree with you, this idea of allyship and amplifying voices. One of the things that I and some of my colleagues do is that I reach out to them before specific meetings and before a meeting where a decision would be made. And I actually share my ideas and thoughts with them beforehand, knowing that this is something where resistance may come across. And I try to, we discuss it before and be like, well, I'm going to say this. If you agree, I would appreciate if you can share your thoughts simultaneously. And I've also been able to like find allies in the group and in the organization where people are more apt to listening to me and supporting me. And I reach out to them. I also have mentors internally where I would reach out to them and being like, I need you to support me in this way. This is something that I need, especially when it's something that is affecting so many people, especially our trainees who don't have as strong of a voice often that is heard clearly. And that's a way that I've been trying to address systemic racism. But you're right, as all of you guys have suggested, that it doesn't work all the way, all the time. But knowing that there's a group and creating a network of allies has really, really been helpful. And I feel like that's something that can be done even as a trainee among your own core group. And I think it can be done as training directors, as faculties, and so on. I feel like this is a lifelong journey, and we need to kind of keep fighting these issues of systemic racism and social inequities. Well, thank you so much for sharing your thoughts. I'm curious if you had anything else that you would like to share with us today. Well, I appreciate your time. Thank you.
Thank you. Thanks for inviting me.
My pleasure.
Thank you so much.
I appreciate the opportunity to talk about social injustice and equities and health disparities and what our trainees are going through, because we want them to make it through residency, to be able to take our places and bring up the next generation of learners who will hopefully reflect what our diverse society is.
Right. And address this with our patients who can carry this on in future. Great. Thank you.